Good morning, everyone. Today we'll be talking about developmental anomalies of the teeth, which is one of the main chapters in old medicine subject. Today we'll be talking about the various types of developmental anomalies related only to the teeth structures, in the size, in the shape, in the structure, and what are the causes and how do we treat it as according to the problem persists. Now, in this development anomalies, we can broadly classify them depending upon what kind of developmental anomaly it is, depending upon whether it is an anomaly in the size of the teeth, or in the shape of the teeth, or in the number, or in the structure. Now, be it any developmental anomaly, the basic etiologies remain the same. It could be either hereditary or genetic or traumatic during the developmental stages of the formation of the teeth. Any particular external trauma or insult to this particular tooth bud will result in a developmental anomaly. So the etiological factors remain the same, but the cause and the effect will be slightly different depending upon what stage of a formation the tooth bud is in. So moving on to the size of the teeth, we have basically a microdontia or a macrodontia. So developmental anomaly can either be smaller than the normal size or larger than the normal size. Smaller, we call it as microdontia, larger, a macrodontia. Now within this microdontia, we have something called as true generalized and relatively generalized. Now, true generalized is actual reduction in the size of the teeth. I mean, that means to say the natural anatomy of the tooth is compromised over here, and there is actual reduction in the size of the teeth because of the various etiological factors. Now, one of the main reasons behind this true generalized microdontia is a pituitary dwarfism, wherein all the structures or the growth hormone itself reduces in its secretion, so it results in smaller sizes teeth formation. Now there is also relative generalized, wherein the tooth is actually normal in size when compared to the standard anatomical size of that particular teeth, but its surrounding structures are relatively larger in appearance, so that gives a smaller appearance to the teeth. Now if we take the example of this relative generalized to the teeth in particular, now the jaws might be larger in size because of various reasons, or because of a disease, or it would be physiological. Now there could be spaces between the teeth, which gives the impression that the teeth are actually smaller than the actual size, which is not the case. Now in those cases, it is called as relatively generalized, and normally it usually involves single teeth. The most commonly affected teeth is the maxillary lateral incisor. We also call it as peg laterals. Now then followed by the third molars, your wisdom teeth, and then the maxillary and mandibular second premolars. Now similarly, we also have this case in macrodontia, wherein again we have true generalized and relatively generalized. Again the situation is the same. The true generalized, we have actual increase in the size of the teeth seen in pituitary gigantism. Also relative generalized, we have a few conditions wherein the jaws might be larger, smaller in size than the normal. Or we also have hemifacial hypertrophy, wherein half the face of the facial structures might be atrophied or hypertrophied depending upon which half is affected. So that gives an appearance of a macrodontia, which is not the case actually, and that is called relative generalized. This also usually involves a single tooth. We can see the radiographic structure, wherein the central incisor, this is a case of hemifacial hypertrophy, wherein the left side is normal in size, whereas the right side, its contemporary, is larger in size. Now moving on to the disturbances in the shape of the teeth, which is the most common anomaly we come across, which the general population is more affected with this kind of a developmental anomaly rather than any other kind of anomalies, wherein we have a series of a spectra of disturbances in the shape of the teeth, which we'll be talking about right now. The first among them is gemination. As the name suggests, there is a gemination potential for the same tooth bud to give rise to two teeth from the single tooth bud. So there is the tooth bud tries to give out two different teeth, wherein it fails. It doesn't totally give out two particular teeth completely, but there is some kind of contact between these two teeth, as you can see over here. This is actually an attempt of the single tooth germ to give rise to two different teeth. Now this could be, we can see either two completely divided crowns, or it could be partially divided. They could be joined by the roots. So there's different types of gemination, wherein it can be seen both in deciduous and permanent teeth. This is one of the case wherein a permanent teeth, your permanent central incisors, both of the tooth germs have tried to divide into two different teeth, so giving rise to four central incisors, which are smaller than the actual counterparts. Now there is a joining of these crowns at the root level, but the crowns are partially fused with each other. Now similarly, we have something called as fusion, whereas it is just the opposite of a gemination, wherein two different tooth germs, tooth buds, try to fuse together, giving rise to the appearance of a single tooth, wherein it can be totally fused or it could be partially fused. Now this is also seen both in deciduous and in permanent teeth. Now the fusion may be complete or incomplete depending again upon at which stage of tooth development the particular etiological factor has acted upon it. So the cause, again, it could be physical pressure, or trauma, or a force. There's also genetic predisposition. We can see this particular central incisor in the deciduous teeth, where the right upper central incisor, there is the particular tooth germ, central and the lateral, they join together, and there's a partial fusion of the crowns of both the central and the lateral incisors. Now the root canals, again, as depending upon which stage this particular fusion has occurred, the root canals could be completely fused, or it could be separate, and it is more prevalent in the anterior region. Now then we come over to concrescence. The basic word suggests that there's some kind of cementation between two different teeth, or two different tooth germs. Now that's basically what happens in concrescence. There is unity between two different tooth germs at the level of cementum only. So there is fusion which occurs after the root formation. So that basically tells us why there is fusion at the cementum level. So basically this, after the tooth root formation totally occurs, then there is a fusion of these two teeth at the cementum level. So that gives an appearance of a concrescent teeth. Now there's also dilaceration. Dilaceration is one of the most common developmental anomalies, where there is acute severe bending of the tooth root, giving rise to curved roots, as you can see in this particular diagram. The bend may be occurring at any length of the root. Predominantly it is seen in the apical region. Again, this is because of trauma during the tooth formation period. Here we can see an extracted dilacerated tooth, the dilaceration occurring at the apical end. Now then we have dens indentate, also called as dens invaginatus. Now what happens basically over here is there is invagination of the tooth structure, both the enamel and the dentin, into the original tooth structure before the process of mineralization takes place. So what we find over here is a normal tooth structure wherein the invagination has occurred from the occlusal end into the tooth structure, which has a normal enamel and dentin also. So here what you can see over here is the normal enamel and dentin, which has invaginated from the outside surface into the pulp chamber, compromising the pulp space over here, as you can see, or it could be concomitantly found along with the pulp chamber if it is deep enough. But in both the cases, we have the normal enamel and the dentin within the dentinal structure. So this is called as dens invaginatus. Now it's predominantly found in permanent teeth, and the most commonly affected teeth are the permanent maxillar lateral incisors. Again, the etiology being the same, or same spectra of etiological factors, be it the external pressure or growth retardation or distortion of the enamel organ. Predominantly any kind of physical force or pressure from the outside, or trauma or insult to the tooth bud during its formation stages might result in this kind of developmental anomaly. Then we have just opposite of what we have seen in a dense invaginatus, we have dense evaginatus. That means to say that the tooth germ has evaginated from inside to the outside to form a kind of a bulb or a pearl or an enamel pearl, what we call as on the occlusal surface. It is predominantly seen in permanent premolars, hence the name Leong's premolar. It is found as a tubercle or a protuberance at the involved surface. It is usually bilateral. Both the sides of the mandibular jaw are primarily affected, predominantly the premolars. Now then we have what is called as taurodontism, Taurus or bull. So the name arises from the term called as bull-like teeth. That means to say it is a large appearance which is seen in this particular tooth, predominantly because of the expansion of the body of the tooth at the expense of the roots. If you see the schematic diagram over here, you can see the body of this particular tooth has elongated so much that it has compromised the length of the roots. So this is called as taurodontism. Again, it could be genetic or hereditary. Predominantly what happens is, we all know there is, you have this Hertwig's sheath, which in the tooth formation stages, it invaginates at right angles at the level of CEJ. That means to say at the CEJ, this particular Hertwig's root sheath invaginates at 90 degrees, and from there on we have the formation of the root. But in this case of taurodontism, this Hertwig's sheath does not give that 90 degrees angulation at the CEJ, but further down, which increases the body of the tooth but reduces the root portion of that particular affected tooth. Then we have supernumerary roots, again a common anomaly wherein the normal number of roots are exceeded by 1 or 2, predominantly seen in the molars. There might be two types of it. One is called the entomolaris, or called the other is the paramoralis. Both are similar in shape and structure. The only difference is in entomolaris we find the supernumerary root on the buccal side, whereas in paramolaris we find the supernumerary root on the lingual side. It is predominantly seen both in the maxillary and the mandibular regions, primarily the bicuspids as well as the cuspids. Now next we have the disturbance in the number of teeth. There is a discrepancy in the total number of teeth, which again could be true or actual anodontia, or it could be relatively that there might be a lack of teeth clinically, but radiographically there is presence of teeth. According to that, it is again divided into anodontia, supernumerary teeth, and pre-deciduous dentition. Within anodontia, again we have true anodontia, where there is actual absence of teeth, either clinically or radiologically. So there is total absence of the tooth bud itself. So there is congenital absence of the teeth. Now this could be total or it could be partial. The total teeth all over the jaws or all over both the jaws could be affected, or it could be partial to limited to only few number of teeth, depending upon what kind of condition. Predominantly in partial anodontia, we find it in hereditary ectodermal dysplasia, wherein few teeth are found missing totally. Now there is also pseudo anodontia. That means to say that there is lack of eruption of these teeth into the oral cavity. So there is clinically there is absence of teeth. It could give an impression of anodontia, but if we take a radiograph, we find this submerged or impacted teeth within the jaws itself. So there is not actual anodontia, but there is a pseudo anodontia. Now there is also called as false or induced anodontia, predominantly seen in older people, wherein people go in for extractions of those particular tooth due to various reasons. This also can give an impression of anodontia, relative or total. But in actuality, what happened is these tooth have erupted into the oral cavity, have been extracted or have been removed because of various reasons, giving an impression of anodontia. That is your false or induced anodontia. Next, we have supernumerary teeth, predominantly seen in various kind of bony lesions, wherein the number of teeth are increased than the actual set of 32. Most striking feature of supernumerary teeth is each supernumerary teeth closely resembles the teeth which at the location at which it is found. So if you find a supernumerary teeth in the molar region, this resembles a molar. If you find it in the anterior region, it resembles the anterior teeth, both in its shape and structure. Slightly smaller, but it is similar in shape. Now there's a suggestion by various researchers that at this particular location, instead of two tooth buds, one which normally gives rise to the deciduous teeth and the other tooth bud which gives rise to the permanent teeth, in this particular case we might find a third tooth bud which gives rise to the third or the supernumerary tooth. That is the most accepted theory as of now, and this we can see case of supernumerary teeth, wherein in both the upper and the lower jaws we find numerous extra teeth or supernumerary teeth at various locations. Now we have disturbance in the structure of the teeth. This is not very common as developmental anomaly related to the shape of the tooth, but we have what you call as enamel defects and dentin defects. In enamel defects, we have enamel hypoplasia and amelogenesis imperfecta. Similarly, in dentin defects, we have dentin dysplasia and dentinogenesis imperfecta. Now, if we move on to the amelogenesis imperfecta, amelogenesis is nothing but the process of formation and laying down of the enamel matrix, its subsequent mineralization or calcification, and then the final step, which is called the maturation of this particular enamel matrix. Now this amelogenesis imperfecta can affect both the deciduous as well as the permanent teeth. Again, the etiological factors being slightly varied in this kind of a defect, wherein it could be etiological or it could be hereditary or it could be induced, wherein basically what happens is there's malfunction of the enamel proteins. Now enamel forming proteins. Now we know the different enamel forming proteins, ameloblastin, enamelin, tuftelin, amelogenin. These are the various enamel forming proteins. So any malfunction of any of the protein might result in disturbance in the enamel formation, which can take place at any particular stage depending upon what kind of defect we can see clinically. Now, in amelogenesis imperfecta, depending upon which particular stage of enamel formation is affected, we have three types. We have the hypoplastic, hypocalcified, and hypomaturation. Now, if we go through the enamel formation stages, we know that there is initial laying down of the enamel matrix, which gives rise to the normal shape or the actual shape of the particular tooth. Then we have the process of calcification of mineralization, so that hardens that particular tooth structure. And the final stage wherein there is maturation of this particular enamel matrix. That means to say there is intercellular water molecules are totally squeezed out from this enamel matrix, and that gives rise to the hard impenetrable structure of the final tooth structure. Now, if there is deficiency in the formation of the enamel matrix, we have smaller tooth sizes. Hence, we find the hypoplastic, wherein the density, the mineralization or the maturation is all normal, but the tooth is smaller in size. That is called hypoplastic type of amelogenesis imperfecta. We have hypocalcified, wherein the tooth matrix laying down is of a normal size. So the tooth size is normal, the maturation is fine, but there is hypocalcification, that is your mineralization is lacking in this particular tooth structure. So hence these teeth are very soft and fragile, and they can easily discolor because of the lack of mineralization, and hence the resultant malocclusion or the positioning of the particular teeth. Now in hypomaturation, the size of the teeth is normal, the calcification is also normal, but where the problem lies is in the maturation of this particular enamel matrix. So the density clinically or radiographically, we see the similar kind of radiopaque structures as the normal teeth show us. The size is the same, the color is not so different from the normal tooth structure, but it is so soft that if we put in a probe hard, we can easily penetrate the structure of the tooth over there. So that gives rise to hypomaturation type of amelogenesis imperfecta. Now similarly, we have something called as dentinogenesis imperfecta. Now this can be subclassified as three types: Dentinogenesis imperfecta 1, 2 and 3. 1 because it is associated with osteogenesis imperfecta, so there is generalized bony defects along with Dentinogenesis imperfecta. It affects both the dentitions. Now what we see over here is amber color or translucent color of the tooth. Now similarly, the same structure is seen in Dentinogenesis imperfecta 2 also. The only difference here being that both primary as well as secondary or the permanent dentitions are equally affected, but here there is no involvement of the generalized bony structure, so there is no involvement of the osteogenesis imperfecta. We can see the clinical picture over here. Now there is Dentinogenesis imperfecta 3, which is also called as Brandywine type. Now in this what we find is the enamel is of normal thickness. Now the dentin is extremely thin at the expense of the two pulp spaces. So the pulp spaces are slightly blown away. So we radiographically we see what is characteristically called as shell teeth over here. So there is a cervical constriction and a shell teeth primarily because there is a lack of dentin formation in this particular anomaly. So this being your Brandywine type or the Dentinogenesis imperfecta 3. Now then we have dentin dysplasia, which is a hereditary condition, which is an autosomal dominant condition. Now in this there is normal enamel, but there is different kind of atypical kind of dentin. Again, we have two types over here. We have if it affects the radicular portion or the root portion of the dentin, if we call it as radicular dentin dysplasia, or it affects the coronal or the coronal crown portion of the dentin, we call it as coronal dentin dysplasia. So in this radicular dentin dysplasia, it is commonly known as rootless teeth. Now if we see the radiographic structures, we can see somewhat similar to taurodontism, that there is normal tooth structure, but there is enlarged crown portions at the expense of the roots. That is primarily because the dentin deposition in this particular teeth is far more greater than the normal teeth. That is atypical dentin, and this is at the expense of the pulp spaces. So there is complete obliteration of the pulp spaces. So there is very small roots or short or stumpy roots, almost gives an appearance of rootless teeth. So radiographically, in deciduous teeth, the pulp spaces are completely obliterated, but whereas in permanent teeth, we can find small crescents of pulp spaces, but this is all at the expense of excessive amount of dentin deposition at the expense of the pulp spaces as well as at the expense of the roots. Now, somewhat similarly, we have coronal dentin dysplasia. Again, both the dentitions are equally affected over here. Again, the root length over here is normal when compared to the radicular dentin dysplasia, wherein there is total negation of the root length. The root lengths are normal over here, but the problem comes with the coronal part of dentin, where there is lack of dentin deposition and there is a large pulp spaces or pulp chambers which are almost rectangular thistle shaped. So that is a characteristic or typical feature of coronal dentin dysplasia, wherein we have large pulp chambers, all called as thistle tubes. This is at the expense of the dentin or the coronal dentin, and there is also multiple pulp stones, which is all atypical features of this particular anomaly called as coronal dentin dysplasia. Now, teeth also clinically they appear as opalescent colors or opalescent or translucent colors. Radiographically also the density is far more lesser than the normal tooth structures, and we see large pulp chambers with pulp stones. So that brings us to the end of the developmental anomalies owing to the size or the shape or the number or even the structure of the teeth. Thank you.